So we'll be able to discuss the processes. Let's look at the surfaces of the scapula. So the scapula presents two major surfaces. And the two surfaces of the scapula include this surface right here, and that's the posterior surface, it's also called the dorsal surface. Okay? The dorsal surface. So this is going to be the infraglenoid tubercle. Infraglenoid tubercle. So this is going to be the lateral border. Okay, this is going to be the medial border. What is the hallmark feature of the dorsal surface of the scapula? Is the spine. The dorsal surface of the scapula pierces the spine of the scapula. Okay, and it's important to take note of that. Alright, so the dorsal surface contains the spine, and the spine divides the dorsal surface into two unequal fossae. So I have the supraspinous fossa and the infraspinous fossa. And that is that. And this surface right here we are seeing is called a costal surface. Why is it called a costal surface? It is the surface that faces the ribs. It is in contact with the thoracic wall, with the posterior chest wall. So you call it the costal surface. That's the costal surface or the anterior surface or anterior aspect of the scapula. Alright. It has a fossa, this large fossa right here. This large fossa for a multi-pendant muscle. And that muscle is called the subscapularis. The subscapularis. The subscapularis. So for the multi-pendant subscapularis, okay? And then, so this muscle takes origin from the inner to taut of it. And we have, so this is going to be the superior angle, already the belt, of the scapula, alright? So this is going to be the inferior angle of the scapula. So latissimus does a kiss to the inferior angle. Very, very important. So now, we'll be able to discuss the surfaces, and next is the fossae. So how many fossae has the scapula? So it has the subscapular fossa, this origin right here, the subscapular fossa. It has the supraspinous fossa, and it has the infraspinous fossa. And for that reason, occasionally we call the scapula the bone of flame. Why do we call it the bone of flame? It has three angles, okay? It has three fossae. It has three borders. It has three processes. And so we call it the bone of flame, okay? Alright, the next is the articulations of the scapula. So what are the articulations of the scapula? Okay, first, so the scapula articulates with the head of humerus and forms a joint known as the glenohumeral joint or the shoulder joint, the most unstable joint in the body. It articulates the acromion of clavicle, and the joint is formed. It's called the acromioclavicular joint. Okay, the acromioclavicular joint. And these are the various articulations of the scapula. You have ligamentous connections like the coracoacromia ligaments. Okay, so those are things you must take note of when it comes to the scapula. Alright, then the ossification of the scapula. How does the scapula ossify? So the ossification. Ossification. So the scapula ossifies during the 8th week of intrauterine life. So the ossification of the scapula begins during the 8th week of the intrauterine life. And it ossifies from one primary ossification center. One primary ossification center and 7 secondary ossification centers. The one primary ossification center appears in the body of the scapula, okay? While the 7 secondary ossification centers appears in different areas of the scapula. So usually 2 for the coracoid process, okay? 1 for the medial border, okay? 2 for the lateral border, the glenoid cavity, okay? 2 for the spinous process, and that makes it complete. So the total of 7. So you're going to find the secondary center scattered at the region of the glenoid cavity, the lateral angle, at the coracoid process, okay, at the medial border, and at the lateral border. These are the areas where you're going to find these 7 secondary ossification centers. Now, the ossification centers of the scapula is very important, okay, because there are various disorders that arise from abnormal development of the scapula. I'll look at that in the clinical correlates section for the scapula. Alright. So next is the muscle attachment. The scapula is extensive. It has an extensive surface area. So several muscles are going to be attaching on the scapula. And let's look at those muscles. So in order to understand these muscles, take note of these two things. Take note of the surfaces of the scapula and the borders of the scapula. When we talk about the surfaces, the dorsal surface, it is marked by the presence of the spine, and the costal surface is marked by the presence of the subscapular fossa. Alright. Then look at the borders. Both surfaces are going to have medial border, lateral borders, muscles are attaching there. So let's look at this diagram. Alright. So med scholars will be able to discuss the various surfaces and borders. Let's look at the muscle attachments. So we know that this is the costal surface of the scapula. So this surface is the costal surface. What's the easiest way to know that it's the costal surface? There is no spine, so that makes it the costal surface or the anterior surface. So this muscle right here, it's simply the subscapularis. That is the subscapularis muscle, okay? This muscle right here, the infraglenoid tubercle, is the origin of the long head of triceps. Long head of triceps brachii. Triceps brachii. Triceps in the sense that it has 3 heads of origin, and a brachii, it goes towards the arm, okay, and helps in extension. And we must attach this brachii because we also have the triceps serratus, where we combine the tendons of the gastrocnemius, the soleus, and the plantaris in the lower extremity, sort of the posterior muscles of the leg or the calf muscles. Alright, so we must qualify that. Then we also have this muscle right here. Very important. So the muscle at the medial border of the costal surface, it has serrated edges and its fibers moves anterior. So it's called the serratus anterior. So the serratus anterior, or the climbing muscle, this is the serratus anterior. So the serratus anterior is the climbing muscle. So it is the boxing muscle. The boxing muscle. Okay, so take that, it is the boxing muscle, the serratus anterior. And we also have a muscle here. This muscle right here are 2 in 1. At the tip of the coracoid process. The tip of the coracoid process, okay, is attached 2 muscles at the tip of the coracoid process. We have 2 muscles there. So we have the short head of biceps brachii. Short head of biceps brachii. It's an obedient head though of biceps brachii. So it takes away from the tip of the coracoid process. And then this second muscle here is the coracobrachialis. Coracobrachialis. So the coracobrachialis takes away from the tip of the coracoid process and inserts somewhere, okay, at the medial aspect of the mid shaft of the humerus. And the level of insertion of coracobrachialis is an important landmark in the upper limb because so many events happen there. Alright, that's the coracobrachialis muscle. So then we have another muscle here. That muscle is going to be your pectoralis minor. Your pectoralis minor. So the pectoralis minor lies deep to the pectoralis major. And this muscle crosses the axillary artery and divides it into 3 parts. The first part, second part, and the third part of axillary arteries. That's the pectoralis minor muscle. Okay? These are ligaments. These are ligaments. These are ligaments. So this ligament right here is the suprascapular ligament. By this ligament, the coracoclavicular ligament. Coracoclavicular ligament. So these are the ligaments we're going to find them. It takes away from the base of the coracoid process and it projects out. Alright? From the tip of the coracoid process and it projects out. So this is the suprascapular ligament. Okay? So this muscle right here, close to the suprascapular notch, we have a muscle close to the suprascapular notch. That muscle is called the inferior belly of omohyoid. This is the inferior belly. Inferior belly of omohyoid. So the muscle here is the inferior belly of omohyoid. So the omohyoid muscle has a superior belly and an inferior belly. So the inferior belly of omohyoid is attached close to the suprascapular notch. Okay, it's the inferior belly of omohyoid. So this muscle right here is the serratus anterior. It has several digitations, it has serrated edges, and it moves anteriorly, and it takes the boxing muscle. So we're able to appreciate the muscles we can see in the costal surface of the scapula. So what is the largest muscle then? Of course, we have the multipennate subscapularis muscle. So these are the muscles attaching at the costal surface. We're done with that. So back to the dorsal surface. The dorsal surface of the scapula, the most prominent feature is simply the spine of the scapula, and divides into a supraspinous fossa and infraspinous fossa. So let's start from there. So this muscle right here is the supraspinatus muscle. It takes origin from the supraspinous fossa of the scapula, and guess where it attaches? At the superior impression of the greater tuber. Okay, this right here is a ligament, and this ligament is simply a suprascapular ligament. Suprascapular ligament. And this ligament here is the coracoacromial ligament. Coracoacromial ligament. Of course, it extends from the coracoid process to the acromion. That is why it's called the coracoacromial ligament. Alright. So when you look at the spine, on the medial aspect, it presents a muscle. Just at the superomedial aspect of the acromion, okay? At the superomedial aspect of the acromion, you have this muscle, and it's called the trapezius. You remember we said the trapezius is the Schrödinger muscle, and is supplied by the spinal part of accessory neck. Alright, so now we have this other muscle here, on the lateral aspect of the acromion, and that muscle is called the deltoid. So which fibers of the deltoid? The intermediate fibers of the deltoid are taken origin from this one. The intermediate fibers of the deltoid. So it's going to converge with the other two fibers of the deltoid. It's going to insert on the anterolateral aspect of the mid shaft of the humerus, particularly at the deltoid tuberosity. That roughened edge we're going to see at the humerus. Okay. So, of course, this is simply the capsule of the shoulder joint or glenohumeral joint, and this right here. This muscle right here, on the upper medial corner, at the upper medial corner of the dorsal surface. This muscle is called the levator scapulae. Levator scapulae. So it elevates the scapula. It is a joyful elevator of the scapula. That is the levator scapulae. This muscle right here, just beneath the levator scapulae, opposite the root of the spine. This muscle right here is called the rhomboideus minor. The rhomboideus minor. Or you call it the rhomboid minor. The rhomboideus minor or the rhomboid minor. So the levator scapulae takes away from the upper medial corner or border, upper medial border of the dorsal surface from the superior angle to just above the root of the spine. Okay? While the origin of the rhomboideus minor, okay, is at the medial aspect of the dorsal surface, opposite the root of the spine. I call it rhomboideus minor or rhomboid minor. Then we have this other muscle here. This one is called the rhomboideus major. The rhomboideus major. Or the rhomboid major. There's something interesting about these muscles. These three muscles right here are supplied by the nerve that governs the medial aspect of the dorsal surface. And that nerve is called the dorsal scapular nerve. The dorsal scapular nerve. So the dorsal scapular nerve, or the nerve to the rhomboid, okay, it supplies the rhomboideus major, the rhomboideus minor, and terminates by supplying the levator scapulae, the proud elevator of the scapula. Alright. So this muscle right here at the inferior angle of the scapula, it's the climbing muscle partially took some fibers of origin here. And that muscle is called the latissimus dorsi. So this is the latissimus dorsi. Latissimus dorsi, climbing muscle. Usually, it takes origin from the wide area at the back, so that's lateral back, the side. It takes origin from the wide area at the back, and it moves up and narrows and inserts at the intertubercular sulcus of the humerus between the medial limb and the lateral limb. So between the insertion of the teres major and the bilateral insertion of the pectoralis major, we are going to have the latissimus dorsi at the floor of the intertubercular sulcus. Alright, so we have another muscle right here. So this muscle right here is the teres. Is the teres major. The teres major takes origin, okay, at the lateral border of the dorsal surface close to the inferior angle. Is the origin of the teres major. And this teres major is going to insert at the medial limb of the intertubercular sulcus. Why these two muscles right here? This muscle right here is the teres minor. The teres minor. So it takes origin just above the teres major. You need to know something about the teres minor muscle. The origin of the teres minor muscle was interrupted by a vessel. And somehow this vessel has no respect. So it interrupted the origin of the teres minor. Okay, so the teres minor will continue. So it interrupted the origin of the teres minor. And this blood vessel is called the circumflex scapular artery. So the circumflex scapular artery, circumflex scapular artery, interrupted the origin of the teres minor. We have the teres minor here and the teres minor here, and in between is the circumflex scapular artery. Okay? Then, of course, this is your infraglenoid tubercle. It is simply a colony for the long head of triceps. The long head of triceps. So it takes origin from here. The long heads of triceps brachii. Alright, so these are very important muscles that we should know, and we'll be discussing next the clinical correlates, important clinical correlates pertaining the scapula. And they include number one. So we have scaphoid scapula. Scaphoid scapula. Scaphoid scapula. So the medial wall of the scapula can be too concave. This increase in the degree of bend or concavity is what is called scaphoid scapula. Then number two, when there is injury to the long thoracic nerve, the long thoracic nerve is also called the nerve to serratus anterior. The long thoracic nerve is also called the nerve to serratus anterior, or the nerve of Bell. Injury to this nerve is going to affect the innervation of the serratus anterior. And what happens? There will be atrophy of the serratus anterior. So atrophy of serratus anterior. That's number two. And when there is atrophy of the serratus anterior, what happens to the medial aspect of the scapula? So if you look at the medial border of the costal surface, the serratus anterior has atrophied. If the person tries to push an object, the medial border bulges out like the wings of a bird, and this is called winging scapula. So winging scapula, following paralysis of serratus anterior, which is a consequence of injury to the nerve of Bell or the long thoracic bell. Okay, so we also have scapular dyskinesis. Scapular dyskinesis. Scapular dyskinesis. Kinesis here is referring to movement. There's what is called the scapulohumeral rhythm. I'll take that in a separate lecture, okay? But there needs to be some degree of rotation of the scapula with respect to the humerus to accomplish some movement. And once the humerus is unable to do this, due to some pathological conditions or due to trauma, you call it scapular dyskinesis, okay? And number five, we have what is called the Sprengel's deformity. The Sprengel's deformity, S-P-R-E-N-G-E-L''S. The Sprengel's deformity was first reported by Otto Gerhard Karl Sprengel. He was a German surgeon who described this case in 1891. And what is Sprengel's deformity? During the development of the scapula develops in the neck region. And as development continues or furthers, the scapula descends to lie on the posterolateral aspect of the chest wall. The failure of this descent due to alteration in the signaling in the development of the scapula, that's what is called the Sprengel's deformity. So the scapula remain higher up on the medial aspect, okay, of the posterior chest wall. That's what is called Sprengel's deformity, first described by a German surgeon. Alright, so another clinical correlate is fixation of the scapula. Scapular fixation. Then another I'm going to be describing is rhomboid muscle strain. So there can be strain of the rhomboid muscle. Okay, injury to the dorsal scapular nerve will lead to paralysis of the rhomboids and levator scapulae. Okay, so injury to dorsal scapular nerve leads to paralysis of the rhomboids and levator scapulae. All right, there could be congenital abnormalities associated with development of the scapula. So the scapula is poorly developed, partially developed. You call it scapular dysostosis. Remember clavicular dysostosis? We have scapular dysostosis. All right, scapular dysostosis is number 9. Scapular dysostosis. So then number 10, we probably have scapular asymmetry. Scapular asymmetry. Which condition can we find this? When there is unnecessary curvature of the spine, as seen in scoliosis. So the two scapula will not lie at the same level. We call that scapular asymmetry. So it's in scoliosis. Okay. Then what if the suprascapular foramen gets angry and we don't want to transmit the suprascapular nerve? The suprascapular nerve tries to force its way, it gets entrapped. That's the nerve entrapment. You call that suprascapular nerve entrapment. Suprascapular nerve entrapment. Suprascapular nerve entrapment. Okay, so let's add a few more. The scapula can fracture, but it's not very common. So scapular fractures. It's not very common because the scapula is surrounded by lots of muscles. Okay, so the trauma must be heavy to cause fracture of the scapula. So we've been able to discuss the scapula, MEDSCHOLARs, and we started from introduction, what is scapula, using a series of diagrams to illustrate the borders, the surfaces, the angles, the processes. And we talked about the ossification, the foci, the articulations of the scapula. The last thing we're going to discuss is simply how to know the anatomical position and the side determination of the scapula. This is it. First, number 1 is that the spine of the scapula always lies at the dorsal surface of the scapula. That's number 1. Number 2 is that the glenoid cavity of the scapula is directed laterally. Okay, when you remember that, you know that the inferior angle lies on the inferior aspect of the scapula. When you're able to remember this, you can tell the side in which it belongs. Okay, and always tell you that your coracoid process, okay, moves on the lateral aspect just above the glenoid cavity. So with this, you can tell of the side in which the scapula belongs. We're able to discuss the shoulder blade on the posterolateral aspect of the thoracic cage. So up next, we're going to discuss the humerus, the proximal long bone of the upper extremity. See you next time.